diagnosis is like a solid entity. I don't know how you kind of think of it as that way, right? Because sometimes we bill for diagnosis. So it kind of really seems really serious and fixed. But I don't really think it is. I think it's kind of, to me, like a working hypothesis. You know, and if you go back to nursing school and you did that nursing process, there's always like a plan for evaluation. And everything you do in a plan evaluates your diagnosis. I can't think of something in there that does not evaluate your diagnosis. Because even a referral to a specialist is an evaluation of your diagnosis. Right? Even you empirically treat someone for bronchitis, you know, you say it's bacterial, right, of course, and you give a Z-Pack. You're testing this hypothesis. If they don't come back, you're thinking it's probably not that type or it's not sensitive to that, right? You're testing this. So, I don't know the time. Yes. She's checking that. I see. We got, this is actually like one of the last places with a battery in the clock. Most places just don't change it anymore. They keep the clock up for a year and then they just take it down. It falls off eventually, the nail rusts and then the clock falls down. So yeah, we also want to be at risk when we hear certain symptomatology of what's going on. Right? We sometimes we have there's a plus side and a negative side. Sometimes we're very quick to come to a conclusion. I have chest pain. What is it? What is it, guys? Come on. Of course, it's a heart attack. Can you think of other causes of chest pain? Anxiety. Anything else? Okay, something lung, right? Oh, yes, right. Other problems with the heart. Anything else? GI issues.
That's right.
GERD. So that's GI. Anything else? Trauma. Some trauma, like a physical musculoskeletal. Right? PE, the pulmonary issues. Right. So there's a lot of different reasons. So we tend to want to. You know, this is one of the trappings in sort of diagnostic reasoning, is narrowing the scope of possibilities too early. Right, so we don't want to do that because we run the risk that we're going to overlook good information. And then suddenly, if we don't follow a methodology of getting a good history or doing a good physical, we tend to highlight things that we think support the diagnosis and ignore things that we don't. Right, we become very biased on the subject. But again, we also know probability. Someone says this and they have other symptoms. I'm diaphoretic on my left arm. It supports maybe an MI a little bit more. But as long as we have the possibility, we want to kind of stay open as long as possible and as long as it's safe and judicious, and then only close when necessary. Does that make sense?
Yeah.
It's a thinking process. Because if you close too early, you're going to miss information. And not everything is the obvious answer. Of course, right? This is a good example, but I'm not going to read this thing. That's a bad example. It looks very short, doesn't it? So that's at least it's... So who's going to ask about past medical history? Give it to me. Who wants to do it? You suffer from any chronic conditions. Okay, that's one question. That won't capture all of your medical history. Anything else? Ask me some other questions. Yeah.
Allergies.
Let's just stick with one because you know how many actually your ear. It has to do with when 2 or 3 people speak, you can't understand them. 2, you struggle a lot, right? 3 people, you just can't understand anybody. It has to do with like processing speed of the brain. So suddenly you just can't understand anybody. It's like you're trying to go one word, you're rotating, and then you just hear like. So that's what I can hear. Right? But it's pretty true for everybody. Okay, so what else? So you only capture chronic illnesses. That's very nice. You may actually have to tell people what chronic illnesses are. You assume that people actually know what that means.
Diabetes.
Okay. We're not a medication history. You could ask medication because any surgery. So you have to prompt people sometimes, right? You can't just say what's your medical history because they don't know what that means necessarily unless they're really they're good at this. They're like professional patients. Like my parents are in their 70s now, but before 65, they were pretty healthy, and then 65 suddenly they had a team of specialists. They had a team. They didn't go from I'm just going to go to annual exams. They went to full blown. Here's your team. Yeah. You die, and every year you get one additional one comes onto the team. Right, so they're always, they become that, always at the doctor, always at the doctor.
Those are my in-laws.
So you're going to ask specifically questions about this, right? And be careful about the terminology, right? You may not, like I said, people may not know what chronic means, despite we use this language time and time again. average literacy levels of most people in this country?
Like middle school. Yeah.
And okay, so everybody here has a bachelor's degree, which is like 16th grade. So you're at least in 17th grade here. So, right, can you remember what it's like to be in 8th grade? Can you think like an 8th grader? Just because you've been there, can you switch back in?
No.
I can't do it either, right? So remember, that's a limitation of us. We cannot easily switch back into that mentality. But somehow we have to learn ways to do it. You know, there are published ways to do it. There are, you know, there's apps that, you know, will look at some sort of literature and tell you what the average grade is because there's a certain number of words per sentence. We're used to fancy APA format, lots of words, lots of conjunctions and commas and semicolons and stuff. Right? That's not what people understand. So you remember words that people don't understand. Ask about who wants to do surgical history.
So we triage any patients that come in through OB triage, and some of the things I have to say is like, oh, have you had any cosmetic surgeries? Because they don't believe that Miami or breast augmentation qualifies as a surgery.
Okay, yeah, okay, good. So that's a good point to point out for surgical history is cosmetic. I mean, Miami.
I know.
I mean, I was at triage in the ER, and this guy comes in, right, doing his blood pressure on his arm. And his arm, I was feeling his bicep. I was like, did you have anything? Well, that's kind of hard. It's your workout plan, man. You know? Oh, no, it's an implant. Honey, you can get them anywhere or something like that, right? I mean, you want silicone, you want the butt, you want the toes, you want a bigger nose, you want a smaller nose.
It's true.
You want bigger ears, smaller ears.
I hate that. You can do pounds, everything.
Yeah, so it's, I was like, I mean, it looks kind of buff. It has to like, not pay off somewhere, right? Like, it's just somewhere it's not going to work out. I just know this, right? Okay, but that's a good point about that. So, asking for pregnancies too, right? Sometimes that's a separate area. I just kind of think in my mind it's a separate area, always asking about that, right? So asking how many.
Yeah. Do you usually do you guys ask, or do you go by like the office, like the prenatal and stuff from before?
No, we ask. We ask.
Okay, that's a specialized question, right? But maybe sure you're asking when you ask for pregnancy, like how many times they've been pregnant, and then you can have like how many like children you have. Right, returns, abortions. That could be elective abortions or spontaneous abortions or miscarriages. People prefer that. And how many? Remember, number of pregnancies is not even number of kids.
Right. Labor delivery will be labor delivery.
Family history. Who wants to ask that?
I don't know if that. Sometimes.
Who wants to ask a question? Just give me a question related to that. Any illnesses, right? Sure.
Any hypertension?
Probably closer
cancer.
family rather than further family, right? Any distant cousins? Probably, you know, you're kind of like, your relationship to them is probably similar to the relationship to everybody in this room, right? You know, we're all probably like fifth cousins of each other. It's me, this is a family reunion here, all right? Sometimes you do genograms. The psych, they make you do genograms, right? Because it's kind of cool, right? But this is, you know, I think this point is, it's important that this is a very meaningful activity, family history. But sometimes we take it doesn't really mean anything. Because remember also, there's a lot of environment that goes into this. You know, families live certain ways together. They tend to develop the same chronic diseases. It doesn't always imply genetics. And we are in an age now that we know most things are not really genetics anyway. We know other words like genomics, right? We know other things that it's more about the expression of DNA than rather than what DNA you have. We know we have some junk DNA, right? But it doesn't mean it's expressed all the time. But it's still important. It's definitely required to do. This will be a genogram, right? Okay. So socioculture, this is kind of a big area, right? Some folks call this like social history on there. What might be some areas that are important to identifying this?
If they smoke, if they drink.
Give me a question. Give me a question for like Jeopardy. Not kind of. At least some questions. Yeah, who do you live with? Right? Who do you live with? What else? Do you smoke?
Or do you vape?
Just be careful. Remember, people are like vaping and stuff. And
Vaping.
so weird, like,
You have to ask vaping now.
Well, you gotta ask, right? Do you use nicotine in any form or some sort of way? Right. And there's no perfect questions on this, but you know, we gotta be progressive with our questions, right?
You have it in certain
Because people who are vaping don't think they're smoking.
Right.
Es una cantidad de gente joven
What else would
que
we ask?
nosotros cogemos intubados
Right?
en rostro bomber y todo.
And then they say what? Okay, so you hear that? She asks, do you drink alcohol, right?
18, 20.
8 cups of alcohol, whether I need it or not, right?
Horrible.
Then they say socially. And what do you do next?
How often? What's social? A daily
Yeah, what is your
social?
social, right?
Yeah,
I mean,
what's your
I'm not that social. I suspect you're
How
not that
social are you?
You know what I mean? But what is social to them? Right? Or you maybe even do a case assessment, right? Right? You use a validated tool to assess their risk factors. Because how many drinks should be? I'll do that. Let's see where this question goes. How many drinks should men have in a week?
7.
One a day? Or not? If you're swishing your mouth, it kills the bacteria too. Well, the answer is the study is actually very. You know how they say alcohol for like heart attacks and stuff like this? But if you look at the very interesting study where they kind of looked at a lot of data, you know, that was actually the only indicator where any amount of alcohol, cardiovascular indicator, improved. But everything else, stroke, was worse with any alcohol intake. So the actual amount of alcohol people should be taking is zilch. Because everything beyond that is a risk. Okay, that doesn't mean people shouldn't do it. We're all going to take our risks in life, right? I mean, you take your chances at lunch today, who knows what you had, right? I mean, but understand it's a risk. And we're adults and we can choose it. So we might ask, you know, so the upper limits would be 2 per day for a male. But they can't all occur in one day. That suggests other patterns of drinking, like binge drinking. Right? How about for females?
4. 3 to 4.
4 a day. 4 cases, right? 4 6-packs. Got it. Right? Okay, so it's actually 1 per day, no more than 1 per day. But the actual recommendation, but I said, but if you don't drink, don't start. So I never recommend drink red wine for your cardiovascular disease, right? I mean, it seems like you could drink something else, right, with the same resveratrol or something in there, something with pig, eat blueberries.
You know.
So, okay, so any other questions you might ask about this? So we have smoking history, this one says, vaping, recreational drugs. You know, I use recreational, not illegal, I mentioned this. Prescription drug abuse, right? You don't ask abuse, because abuse, you're not going to get the right answers. Like, do you abuse drugs? I'm going to abuse it. No, you're not going to get the answers you want. You know, do you take prescription drugs that are not been prescribed to you? Sample might be a good way to elicit information. Sometimes if you know they might be using drugs or the drug culture, you might use terminology. Like you actually like it, you know? Have you used speed before? Right, we know that might be amphetamines instead of being like, because it always sound like we're like out of it, man. Like use the magic weed or something, like, you know, something. You're like, what's wrong with this person? Like, where are they from? Come on, man. Come on, you can tell me. So, and not everybody who uses something is abusing it either, right? Even if it's drug use, right? So there is the possibility that people could be using it and not be addicted, right? But we know none of it is necessarily healthy. Marijuana, there's a lot of debate about, of course, right? You know, there is some reasonable purposes for marijuana, so we probably don't get as uptight as we used to, right? You ever seen those like old 50s videos or something about marijuana? They were like really scary, man. They were like, you know, you do marijuana, and they're and the lady would be like screaming, the demons enter my head. Something. I don't know what they were smoking back then, but it was that emotional, like to scare people or something. This was evil stuff. You know, Cage, I talked about this. Do a validated screening tools. And why would you use validated screening tools? What is a validated screening tool?
Cage.
Well, Cage is one example of one, but what is the whole category of validated screening tools? Yeah. So that was a screening tool is like some assessment where you do this, but validated. What does that concept mean? It's been tested in a population. So you know, the problem is when you make you've done that at your BSN level, you made a little survey for people, but you actually never knew if the questions you were asking were testing what you were hoping to test. You kind of assumed they did and they let you get away with it. But that's not how we really do it on a larger scale. Because it's important to know that what we're asking is actually testing what we're trying to get. We need to know that if we ask these 4 questions and we get 2 yes responses, that it does mean there's a risk for alcoholism, for alcohol abuse. They're either at risk or they're currently abusing. We need to know it has meaning like that. And nobody just made that up. They tested this. In certain populations, and it can vary according to cultures as well. So we also asked about safety. You know, we might ask if they have guns in the home. That's not uncommon, right? Any violence at home, any abuse, fire safety, firearms, we mentioned that already. Any environmental exposures? I mean, who here is exposed to environmental chemicals? All of us, right? So it's kind of important. Some people are more sensitive or not. I mean, if you use that Febreze or those plug-ins, right? You know, I mean, if you're a woman and you wear makeup, you're exposed to cadmium, right? Because you know all that powder on your face has cadmium in it, right? What? What do you think that stuff is? I mean, it's like ground up rock. You think they test it for a thing? Very high in cadmium. Because they don't test it. There's no safe. And so you're getting cadmium exposure. The good thing is that the highest source is tobacco smoke. I mean, the second would be makeup on your face. Right? You know, so how many chemicals are exposed? And if you're pregnant, how many of them end up in the fetus? I know we all think of the blood-brain barrier and the little fetal barrier are like perfect systems. You know how perfect they are? Oh, come on, right? You know, people with dementia, they can find herpes virus in a lot of them in the brain. Of course, it rides up the cranial nerve, right? That's where, you know, your little cold sore breaks out on the cranial nerve. So it's not an impenetrable thing, right? And if you look at the environmental working group that on fetuses and babies, you know how many chemicals test in the fetal blood cord? I mean, they pass right through. So asking about environmental exposure, because remember some people are more sensitive and how much it impacts life. And anything toxin you bring in, you have to detoxify. So we're used to, you know, having toxins in our bodies all the time, and we have natural, you know, even if you just eat broccoli, for example, you will get exposed to toxins, because the broccoli, in its universal interest, doesn't have an interest in you eating it. Right? Maybe an apple does. Why? Because an apple is a fruit and it has seeds, and it's hoping to poop the seeds out and do all that stuff, right? Or at least throw the core, if you're more civilized. You know, but a broccoli is like a living, so he doesn't really want to be eaten, so he has chemicals in there. But we can detoxify all the chemicals, so we get a net benefit from it. But think about all over long-term exposure. Right, so they say they, you know, they're on a lot of medications. They have an occupation that, you know, in the hospitals, and they do a lot of waxing on the floors. Is that stuff good for you? They never give us a mask. You notice that? So your body is working on detoxification the whole time.
Actually, in the OR, we do C-sections and different procedures. The Volvi itself produces, I think, it's so harmful to your lungs. It's about like if you smoke 35
what is it?
cigarettes, the Volvi. The smoke that it produces, it's like
To carotid.
it's like if you were to smoke 35 cigarettes a day.
Okay, so you hold their breath. They hold their breath when they do it.
We don't in our ORs. We don't have.
Anybody ever go shop at Macy's? And this is, I can't really say their name. Have you ever been to Marcy's? But they got like a long perfume aisle. Have you ever been that? I swim a lot, so I can hold my breath. I can walk through that thing. It takes like a minute and a half to get past these people. And they're puffing you and spraying it, and you're trying to dodge them, right? I mean, you really will how much the impact of Marcy's. So right, that's an example of it, right? That's things we take for occupational exposures, home exposure, mold in the home. How often you clean your curtains up at the top and how much dust accumulation you get there. If you test, you probably have mold up there. If you have carpeting in your home, who knows what's in there, right? But it's not to get you scared about life, right? It's just these are real. So the one trick in life is just have as minimum amount of exposure as possible. So if you already get exposed to a certain amount in your environment, don't put a plug-in your house. I mean, why self-inflict? You have to take Ubers or something or lifts a lot. Those have those little thingies in there. Man, what a torture. So ask your patients about what might risk be and how they may contribute. Health maintenance, ask if they actually are having primary care, dental care, eye exam, right? Most of your patients are not getting good dental care, so make sure you do good dental physical exams, especially if they're low-income clinics, right? Ask about different medications. We talked about this already. Make sure you're asking about herbal vitamins, supplements, right? Do people take them? How many times have you been to their provider and they ask you they take any medications. You say, why take them? They don't seem to care if you take a multivitamin or not, right? Yeah. Do you know why? Because they don't know anything about these things, right? They don't know what ginkgo does or what coenzyme Q10 does, right? So they don't have any way to put them in their paradigm, so they don't really get a lot into it. But a lot of these herbs can interact with medications. It doesn't mean you should not take them. It just means that you have to have a knowledgeable way. So you should be asking with people what people are taking, you know? Because some supplements, there's a high rate of contamination in them. For example, what are the 3 areas of highest contamination? What classes of supplements? I'll give you the first one. Weight loss supplements.
Uh-huh.
Maybe protein?
Protein, like muscle gainers.
Yeah.
Same thing, right? Pre-workout. Anything? And related to weight loss kind of. What else do people buy supplements for, right? Libido. Libido is the other one, right? I mean, if you're taking your pre-workout and you're feeling jacked up, maybe it's because of the amphetamines, right? Some of them have tested positive for this. Because especially if it's from a company who doesn't check the tail end of their product, right? Maybe it's coming from sourced from a country. I can't say the country, but we'll call them like Chino. Right? I mean, it's not because they don't have potential. It's because they're not there yet. Right? But anyway, so right, are you jacked up because they put all the caffeine in it? It's probably not the amino acid, right? I doubt that's working. Right? It has to, you're jacked up on caffeine probably, right? And if you're lucky, it's not amphetamines in it, right? So review of systems. What is a review of systems? How's it different from a physical exam?
Because you're asking the patients.
Okay, you're asking. This is still part of the subjective. In the SOAP note, this is subjective. So if, right? So when you do a physical exam, right? You know, I'm going to take this area again. Because I see this commonly there. For, you know, if women go into their healthcare providers, you know, they'll get pap smears and their recommendations, all stuff. Men go in there, people hardly even want to look at the board area down there. They don't want to, like, ask about it, what's going on there. They rely a lot upon your opinion of what your perception of is in your genital area. Right? Maybe women don't know this. This is what happens, right? You know, so they'll ask you, is everything okay down there? Yes, I guess good enough. Right? It meets minimum standards, but that's fine. Right? So, but then they never do the physical exam on it. Or sometimes you see them write patient reports, everything fine, in the physical exam. I mean, is there a problem with that? Right? So physical exam should be stuff for you did, and if you have male patients, you should be at least in the physical looking at that area, because, you know, their perception of what they think is now. I was doing a pap smear on a woman right before, you know, and it was a low-income clinic, and that's where I primarily worked. And I'm doing this, and, you know, we're there, and, you know, and just, what are you looking for? I had made an assumption she kind of knew something like beyond the vaginal opening. She kind of knew the world. But she didn't really know it beyond besides like sex or something like this, right? Vagina, you know, that kind of thing, right? Male, female parts. It's perfect union, right? You don't really apparently have to know at the end is the cervix, and that happens to be the opening to the uterus, you know, and then it goes up the fallopian tubes into the ovary. All you have to know is that, you know, the semen goes in and then a stork comes by 9 months later, right? And I guess the time is long enough for a lot of years, people didn't even know there was a connection between the events, right? Because it doesn't happen 2 minutes after, then you say, wait a second, now when I do this, I get a baby, right? 9 months later, you go, wait a second. So the point of all this is that, you know, people don't often know what's down there, right? So be careful the way you ask these questions. Make sure your interview goes in the review of systems, and your physical exam goes in the physical exam, and that's the difference between subjective and subjective is their opinion, objective is sometimes it's your opinion.
Yours.
Right? So it's called like subjective objective, that's what I call it, right? I mean, because you have your biases, believe it or not. But it's supposed to be because you have qualified and you've been tested that you have some knowledge and we call it objective. It's not absolutely objective. Is this making sense?
Yes.
Am I dragging this on too long? I'm trying to make it a little interesting here. SOAP notes, subjective. And I recommend you write your notes in this. This is another format, subjective, objective. What's the A stand for? Right, and that's not kind of the assessment like a physical assessment, right? Assessment is diagnosis in that regard. And remember, diagnosis can be fluid. And plan is the P, but it's also your place to evaluate the diagnosis. And just like when you check a book out of the library, if you don't like the book, you can return it and get a new book. You can always go back and get another diagnosis. And that's why sometimes you make differential lists, right? You use a lot of information. And remember, each section informs the previous section. A good history will inform your physical exam. It's going to help you guide you which parts you should pay most attention. You should be paying attention to all of them, but it's going to give you some idea. After each section, you have some better picture of what's in mind, of what might be going on with the patient. It's, I'm describing it in a slow, kind of rigorous, long-winded process. But really, it's kind of done quickly, if it's done well, that the interview has a purpose to guide your physical exam, to guide your ultimate diagnosis, and to guide the plan. And if you don't get good information, and you can't do physical exam, how can you inform your assessment and plan? Say all you use your chief complaint and a few random symptoms. Right? You know what happens? Every chest pain becomes a heart attack. That's what happens, right? I think we probably in the end get suboptimal care. So keeping things separate, these are the things that go in subjective, these things that go in objective, So objective data would not be laboratory diagnostics you order, but laboratory and diagnostics you review. So at that point, they are now objective. If you're ordering a chest x-ray, that goes in plan. Right? But if you're reviewing their labs from last visit, that's objective. Okay, we talked about this. Here's a quiz. Objective data is more important than subjective because subjective data is lacking in quantification. It's like subjective data is a loser. False. It had the answer at the bottom, I guess. Okay, so physical exam, we're going to go through this quickly. This is really about, this isn't really just about health history. We're here till 10 p.m., right? You're wishing you were in Dr. Alfred class. I had to teach a class, so they say, oh, then we always leave an hour early. I was covering something. Okay, closing the interview, bringing it to a close. All this should have occurred kind of in a timely manner. Really, that's the idea, right? And I'm going to prioritize the idea of give a little summary. Especially maybe in the HPI is a good place to summarize. So what I heard you say is this. You've had some cold symptoms, including a cough for like 2 days now. I know that the cough drops help a little bit, right? Not too much, right? So something like that, right? You can add other symptoms in there, your severity, your pain. And I know when you do have a cough, it's 5 out of 10, but I remember you said it. So and she said, So I felt okay, like it was okay, like we did it, and I think you felt kind of validated that maybe I did pay a little attention. Right? It had a little effect. Sorry. That was okay. That was the intention of that. The intention of that. Who in that beginning exercise in the class? I'm the Bible version. Who felt awkward doing that exercise? When I go around, tell me something about yourself. Okay? So I actually teach mindfulness too, so it's kind of an interesting activity just to be aware of, like when you do that, what it is like to just feel awkward. Alright? There's nothing more than that, right? That's the good news. Right? It's just kind of a moment of feeling awkward. And that's it. And then it goes back to something else. So focus visits, we have our annual physical exams where we see everybody focus visits and where they come. So this is where we make, the old junker car comes in, you choose the one area to work on, probably has something to do with what they think is important that day, according to their chief complaint, along with something that you think is important to work on. They should kind of ideally blend a little bit, and sometimes you have to negotiate that plan, right? But even though you have an old junker car, right, the first thing you do is assess the whole thing so you know what's broken on there, and then you prioritize. But you never, even in a focused visit, forget the rest of the parts of the car. Right? Because then at that point, you're not actually being holistic. Right? You're just kind of being too overly narrowly focused. Right? You're forgetting that perhaps, believe it or not, her respiratory condition or HEMT condition might have something to do with her immune system. It might actually affect her psychology. Right? Because maybe she feels more down. We know that if you have a bacterial infection and makes lipopolysaccharide, that your mood becomes more depressed. right? Maybe you're fuzzy in the head, you're not thinking clearly, right? Maybe you don't even feel like being here, right? So it may have something else. And sometimes people have dermatological manifestations of illnesses as well, too. So we like to break systems up because it's convenient, right? But we know, just like at home, I keep my white shirts in one drawer and my blue shirts in another drawer. But that's arbitrary. That's all arbitrary. In the end, they're all shirts. And in the end, it's your body works as a system. And then we're in this class breaking things up. So focus on what you need to focus within the time reason, but never forget about the other issues. And sometimes you have to tell a patient, we don't have time to kind of get into that today, but I think it's something that we might be able to work on at another time. Never just ignore it. Because it's the worst thing you can do with your relationship with your patient, especially if you're going to be in an environment where you see them. Maybe you're in the ER and you kick them to the curb, right, and you never see them again. I mean, I don't recommend doing it there, but there's that scenario that happens. You don't see them again, so you know, who's been involved in negotiating anything? Right, negotiating things. So there's different levels of negotiation, depending on your relationship with the person you're negotiating with. Right, how many times are negotiations take it or leave it? You say 50% of the time. There's a risk to that, right? Because you take it or leave it, you burn relationships. You only do that with people you don't care about and that you're not going to have dealings with in the future. But if you want to continue to deal with it, like maybe your employer, you negotiate more softly. You give and take and give and take. You don't say, take it or leave it, boss. You don't give me the raise, I'm out of here. Or you don't often do that because there's too much risk. And you shouldn't treat your patients like that and negotiate with them in that style either. Because you're going to burn your relationship with them. Yeah. Right? And you're going to get more just from them. If you're a good provider, who wants to be a good nurse practitioner? All of us. Okay. Well, I didn't see everybody raise their hands. So I think did you raise your hand? Okay, you want to. What was the question? So if you think you're a good nurse practitioner, they're going to be better in your office getting your care than going out to get care from somebody else. So keep them in your office, right? Build the relationship. They're going to get better by you have a good relationship with them, even if sometimes you give the wrong medication.
That's true. That is true.
If they believe this is a healing environment, they're going to get better.
That is true.
Like 20, 25%. I mean, it's just a win, right? So they have to trust you and respect you too. So notes, these are some examples. I'm not going to take the time to read them. And I must have other stuff to talk about. I think you guys want to break it something. Okay, presentation. We already did this. We went through all these sections. We're going to read these. In summary, so very quick, so we're going to do more physical exam. There's lots of parts of the physical exam, right? And, you know, what we're going to learn in this course about physical exam is you're going to learn some of what we're going to learn is really good stuff, and some of it's probably like a little old-fashioned stuff. And that's how all physical exam is kind of taught, right? So in the end, you know, there's considered that first line exam, and then there's a bunch of tools in the back that you might bring up for special occasions. Like maybe I got a knee injury, and then you're going to do that locking